Give me a second, I'll share. Can you see the slides?
Yes.
Ma'am. Just put them in the presentation view.
Okay. Are we ready?
Yep, go ahead.
Well, no, we can't see them. Hit return, Jasmine? No, go back one slide.
Sorry, it's very.
Okay. All right. Well, we'll get started. Claire, do you want to give an introduction?
Oh, I thought Leah did great. I'm a huge proponent for patient priorities care, clinician educator from Mount Sinai. So looking forward to the talk today.
Okay, so we'll get started. So thanks again for letting us come and spend some time with you all. Many of you were part of our prior training doing the facilitation piece for patient priorities care, and now we're moving on to the next set of training around clinician training. So Claire and I are part of the team that's developed patient priorities care, and which involves aligning decisions and care with the health priorities of older adults who have multiple chronic conditions, so many of the patients you see in home-based primary care. Hopefully you completed, some of the introduction training that we've done and describes sort of what this is and why it's important for you and how it works in practice. And so, that's a slide set that's available to you for reference as we move forward. We're also assuming you have some familiarity with the problems, the types of problems that this type of care addresses and who it's for. If you haven't gone through the patient priorities care facilitator slides before, we recommend you doing that as well as this set of training. And we'll talk today about how to translate patient priorities into medical decisions during your encounters with patients. We'll use a series of strategies and offer tips and scripts on how to approach the care of the patient with multiple chronic conditions. And then we'll discuss how to address common challenges that you might face and explain how to be successful in implementing patient priorities care. We have made some portions of this interactive that'll get you the most out of this training, and it will help you with your own decision-making when prompted. So there's a lot here, sort of chock full of information, and I think you can use it as a reference that you can go back to in the future.
Dr. Nyack, this is Claire Campbell. I just wanted to say so we have all of our home-based primary care team here. So some of them are not necessarily doing the identification portion of it, but we have a lot of different disciplines who are on, who are going to be trying to align then after another group does the identification. So just to give you some context.
Yeah, and thanks for pointing that out, Claire. I think that was sort of my assumption. And so some of you have seen the facilitator training, but even if you haven't, I think that this slide set will stand alone. And this session is really about, now you've been given some priorities that have been identified. Now, how do you best take the current options for care and try to align them with patient priorities? So I'm sort of jumping into the next slide. So go ahead and advance, Jasmine. Okay, there are 3 steps to the patient priorities care: identify, decide, and That involves really everyone that's part of this process: the patient, their caregiver, and the full clinical team. That's really all of you all in the audience. Patient priorities care begins with helping patients identify their health priorities. And by health priorities, we're again referring to health outcome goals, the things that the patient wants most in their life and what they want their healthcare to help them with, given their preferences for the sort of healthcare tasks, medications, procedures, self-management tasks. So these are all the different things that are part of healthcare. So really, again, when we talk about priorities, we're talking about what are your preferences for all those sorts of things that are involved in your care, and will those things help you to get to the outcomes that matter most to you? That's your outcome goal. So these health priorities are then identified and transmitted to all the other members of the healthcare team. So we've designed some CPRS templates that you can use to document what you've identified during the facilitation piece and then share with the full team as we now start this next step. The team then works with patients and their caregivers to stop care that might be harmful, but that doesn't really help them to achieve their priorities, and to continue or to start care that does help or that might be more beneficial. It's not just about getting rid of care, it's really about realigning care so that it's more aligned with your priorities rather than just disease guidelines or some benchmarks. The most challenging part of aligning all of these pieces is what really a care coordinator does, or care coordination steps. And that's the primary and specialty care clinicians and everyone on the home-based primary care team, how you're all sort of working together to find care that's doable for the patient and caregivers and is focused on their priorities. And because these things change, it can be an ongoing process where even after doing the alignment, we might have to go back and revisit the identification steps as things might change in your life. So we'll explain how you do each of these steps in the health priorities facilitator and training slides. But for today, we're going to focus primarily on the alignment piece of this process. Next slide. Okay, so now we're going to talk about what happens for a patient who you identify as someone who would benefit from the patient priorities care process in your clinic. So we're going to go through several encounters that involve our patient here, Mrs. B. And together we'll explore how to align care for her to help her to achieve her priorities. So Mrs. B is someone that we talked about in the last session, but for those of you all who are joining us for the first time, we'll go over this again. So Mrs. B is a 75-year-old, and she has a typical story for an older adult with multiple chronic conditions. She has atrial fibrillation, diabetes, depression, reflux disease. She's had a few hospitalizations due to a GI bleed and heart failure with reduced ejection fraction, hypertension, sleep apnea, osteoarthritis, and osteoporosis. So clearly, multiple chronic conditions. She sees a number of different clinicians in addition to you, or now that she's part of the team, you know, she might sees them a little bit less, but they've been involved, especially they've been involved in her care previously, even if they're less involved now in home-based primary care. Often her main complaints during her prior visits and when she comes and speaks to members of the home-based primary care team is really a combination of symptoms: fatigue, a little bit of shortness of breath, a little bit of pain, and some urinary frequency. Recently, she's been bothered by some aspects of her healthcare as well. She has hand arthritis and is taking some NSAIDs, but these produced an upper GI bleed in the past for which she had to actually be hospitalized for a few days. She takes a diuretic for her heart failure that's caused increasing urinary frequency and maybe even some incontinence, which is upsetting to her. So attempts to decrease her diuretic use led to worsening dyspnea. So you really aren't sure what she's taking right now, and she's reluctant because of a lot of these side effects. Okay. So Mrs. B's case exemplifies the complexity of decision-making for multiple conditions. So go forward one slide. Okay, Mrs. B's case exemplifies the complexity of decision-making with multiple conditions. Her clinicians are faced with uncertainty about her care. uncertainty that arises because of the balancing of these different competing conditions that she has. Mrs. B's case, the treatment for one condition, like for her heart failure, might exacerbate another condition, for example, her incontinence or urinary frequency. Her treatments that help her for one condition cause a potential problem or harm, and so all of this can be burdensome. For example, the NSAIDs that produce the GI bleed in her hospital stay. Given the general frustration and not really being sure about how best to approach her care, she's in these recent adverse events that she's had. Mrs. B, primary clinician, which is now probably one of you, asked her nurse to help to do this process of identifying our priorities so that we can actually align her care so that it's more consistent with her priorities. This nurse was trained in the patient priorities identification process, and the patient's priorities were identified. Now, it doesn't have to be, let's say, a nurse in home-based primary care. It can be a range of health professionals, such as a medical assistant, an APRN, a care coordinator, a social worker, a pharmacist, and even a nurse practitioner or a physician. We also have online self-directed websites that we're developing that maybe a family member can help with the patient just to help them along in this process. But I think for home-based primary care, it'll still be important to have one of your team members be the facilitator that does that process of identifying priorities first. Okay, so we're on the next slide. So this slide gives an overview of the process used to identify a patient's priorities. So we have a member of the healthcare team identifies the patient's priorities during a brief encounter. The priorities are then recorded in CPRS and include information about reliable, specific, and actionable outcome goals and care preferences, and enough information for you to use during your encounters with the patient to help to align care to achieve these priorities. Next slide. Okay, so next is, here's a template that we've used following Mrs. B's session to identify her priorities. Ideally, this template is made available in CPRS, and you can use it to review during your visit. The template includes the following things. Number one, what matters most. This is the patient's values and reflects what's important to them in their life. And these are the kinds of things that don't tend to change that much. They've been important for them for a long time. They're likely to be important for them for more time in the future. However, what might change is the health outcome goals. And that's how we transform these values into specific, realistic, actionable goals. Now, the goals should be linked to the values. They're not really supposed to be about a disease or a lab value or a biomarker. They're really supposed to be goals that are related to the patient's values and what they would like to achieve in their life. In addition to goals and values, we have healthcare preferences. And these preferences include things such as self-management tasks, healthcare visits, test procedures, as well as medication and other services and supports that you might find valuable or helpful so that the patient can achieve what's important to them. There's also things such as self-management tasks, visits, and tests and medications that the patient might find burdensome, too difficult, or not helpful. And it's important to identify this and document it so that we can understand why patients might not do things because they find them very burdensome. And so these are things that we should really consider giving up on. There's a final step, and this is called the one thing. I think if you click next there. The one thing is a health problem, a symptom, or other item that the patient wants to focus on primarily as sort of a first step. And this is the thing that's getting in the way of achieving the outcome goal. This one thing helps you, the clinician, and the patient get on the same page in terms of aligning care with priorities. Next slide. Okay, so let's review what Ms. B said, and then we'll discuss how this information can be streamlined into your decision-making process to help you move forward to the care alignment step. So in Mrs. B's case, we have two specific measurable health outcome goals. Number one, she wants to be able to watch her grandkids after school for about 2 or 3 times a week. Number 2, she wants, well, I guess this might not apply as much to home-based primary care, but in a typical outpatient clinic, we could think about an older adult who wants to volunteer in the library 2 times a week and be able to handle books while at the library. As you begin to see that these outcome goals can inform your medical decision-making process, how you think about things, and really the interplay of a number of her health conditions and how they're likely to affect her being able to get to her goals. So as you can see here, these goals are not specific to one chronic condition. They really overlay several chronic conditions all at once. And so you've got to think about that in terms of helping her get to achieve her goal. You've got to sort of, in your mind, weigh through the different chronic conditions and how each of them individually, but more likely together, are interfering with her achieving her health outcome goals. So to be active with her grandkids 2 or 3 times a week, she needs several hours where she can go without being active, without getting short of breath or fatigue. Now, if someone who's trying to volunteer in the library, she needs to be able to hold books without having pain in her hands, and she needs to be able to walk around and have enough endurance to do reshelving of the book. So you can see these aren't just sort of mundane things for you to think about that aren't linked to her health or her medical condition. In fact, these chronic conditions really dictate to what extent she's able to or not able to get to her outcome goals. So first, you should think about which conditions are affecting her ability to achieve these goals, and then start thinking about her current care and how can we change her current care so that can actually help her to better achieve her outcome goals. It gets a little more complicated because she might have some healthcare preferences that need to be considered. So again, the preferences are the things she's willing and not willing to do to get to her goals. She's been willing to do some things like exercise or physical therapy, and to some extent, some laboratory tests or some imaging. She's willing to take some medication if they're tolerable and helpful, but she's on a lot of medication and some of them are causing her trouble, and she doesn't really want to take all of her medicines. And then she also admits that she actually hates her CPAP machine and has been avoiding it all this time. And she would like to stay out of the hospital as much as possible. As you can see, her main complaint to you is her fatigue. That's the one thing that she'd like you to focus on, which is to be less tired so that she can watch her grandkids. Next slide. So you're given that information, and now you need to start thinking about the care for Mrs. B. And it helps if you give it a pause and sort of start by answering the following questions. Try writing them down. And remember, there aren't any right answers. This is just to get you thinking about this process of care alignment. So first, what challenges do you face when taking care of patients like Ms. B? Number 2, how might you make decisions that are consistent with Mrs. B's priorities? And number 3, what trade-offs arise when aligning care with Mrs. B's priorities? So when we get to the next slides, we're going to discuss these trade-offs and their considerations. And then we're going to try to identify some strategies that you can use to get to your goals. But maybe before we jump into that, just to get us engaged here a little bit and get you guys talking some, tell me what you think in terms of what are the challenges you think you might face as you're making decisions about her care and how that's consistent with her priorities. What are some of the challenges you immediately think might be an issue? Maybe Dr. Campbell, I can get you to volunteer.
Sure. So I guess I think one of the challenges, and I guess this is kind of taking a step back even, that if we're trying to get her to fulfill some of these goals of being able to take care of her kids, just from a practical standpoint, whether or not that's going to be, increasing her fall risk too, which I know is a huge priority for home-based primary care to reduce falls. I see that being a big challenge, and trying to talk with her about maybe even changing her medications around. Sorry, I see that Michelle has said something too, like with the unrealistic expectations as well. Veteran.
Yeah, so unrealistic expectations are definitely something that comes up frequently. And that's why it's really important to try to make those goals as much as possible, realistic and something that's measurable. And sometimes you don't know right away. Let's say a facilitator came up with a goal, and on first blush, you're like, ooh, I don't know if that's really that realistic. And so you can try to reframe it when you see the patient and make it a little more realistic, but sometimes you just have to sort of be aware of and acknowledge that it might not be realistic, but we're going to try our best to do that alignment. And then if it doesn't work out this time, then sometimes it's something that that needs to be tackled. Okay, let's move on to the next slide for the sake of moving us along. So let's review some of the challenges that commonly occur. It's not so specific to Mrs. B's case, but these are these common challenges in aligning decisions with patients' healthcare priorities. So the first thing is uncertainty. So a lot of times we're not 100% sure what the best decision is. We talked about in the intro slide that there's a lot of uncertainty because there's not perfect evidence for patients just like Mrs. B. So we don't always know what the right treatment is for the mix of her offending conditions. So that's part of it, is we're sort of not sure about what the best thing to do is. And as you said, Dr. Campbell, that sometimes what we decide to do might actually cause more harm than good. So there's some degree of uncertainty about the potential unintended consequences of something that we might decide to do. In persons with multiple conditions, there's always uncertainty about the benefits and the harms of individual treatments given the complexity of these competing conditions. So again, there's often not a right answer or a best option, and sometimes we have to sort of trial things out. We'll get into that a bit when we get to our strategies. But often we're left wondering where to start with these complexities. Yeah, go to the next slide. So another challenge that comes is from having different perspectives between the patient, the caregiver, and the clinician. And it may be that the patient and the family members together are having a different perspective than the clinician. And then sometimes there's just different perspectives between the patient, the caregiver, and the clinician, the three different groups. Common situation that occurs is that the patient might be focused on what they're having to face today, tackle today, an immediate symptom or issue. And the clinician, though, is focused on preventing some future bad event, and their perspective is more into the future, and they sometimes ignore what's happening today. So an older adult with multiple chronic conditions might come in with concerns about a bothersome symptom that they want taken care of. For example, I'm getting too dizzy from my blood pressure medicine, and that's the most important thing for me today. Can you help me get rid of this dizziness? The clinician is appropriately concerned about an adverse event that can happen from poorly managed hypertension, such as a stroke or a heart attack. So the clinician is concerned about longer-term outcomes that the treatment is intended to prevent, but the patient is bothered by something more immediate. So that's what we call a trade-off. So there's a trade-off here that exists. So what do we do in that situation? Next slide. So differing perspectives among clinicians can also be a challenge. That's another challenge. So this may occur between a primary care clinician and a specialist, or between two specialists or two members of your care team who are focused on maybe different diseases or different aspects of that patient's situation. The clinicians vary in how or whether current evidence or guidelines apply to this specific patient, and how they broach these differences in perspective often can lead to conflicts in terms of the recommendations they give to the patient. So the clinician may differ on which conditions to focus on and also which outcomes to target. So for example, it's the cardiologist's job, for example, to worry about the heart attack or the stroke, and so they might really be focused on getting the blood pressure down no matter what. But the primary care provider or the home-based primary care provider is actually worried about dizziness and falls and hip fractures. And so, is really mindful of, are we taking too much antihypertensive medication, or maybe we need to lower it, even if it has some marginal increase in the risk of heart attack. So we'll talk about these things and other challenging situations in the care of older adults with chronic conditions. Next slide. So in our work with many patients and clinicians, we've come up with some strategies. So these are the strategies that we use to address the challenges that we just described and some of the areas of uncertainty and conflict. And these are strategies for aligning decisions with patients' health priorities and addressing some of the key challenges. And we're going to describe the strategies, give you our rationale for why we think that they might be helpful, give some examples of how you can use the strategies in caring for Mrs. B, and then if we have some time, we might practice doing them as well. Next slide. So there are three main strategies that we're going to talk about today, and they come out of work that we've done with clinicians and patients over the last 4 years, developing and implementing patient priorities care. And they also come from some of our own clinical experiences caring for patients with multiple chronic conditions for many years. There's certainly not, these are certainly not the only three strategies you can use, but we think that they've been proven to be feasible, practical, and helpful. And so we want you to consider using them as a good foundation. So strategy one is use the patient's priorities as the focus of communication and decision making. So rather than diseases or guidelines, we want you to use the priorities as the basis for thinking about your decision making and how you're communicating with the patient, the family members, and other clinicians. The second strategy, click. The second strategy is to use serial trials to determine the optimal interventions that might be used. So, and so we're going to use serial trials of different interventions, or maybe the same intervention, but you're going to tweak that intervention a little bit. And we're going to keep doing that tweaking and decide whether or not we're where we need to be with that tweaking based on how well we're achieving the patient priority. So attaining the priority is the measure of success, and then the sort of serial trial is the tweaking of that one particular care recommendation or several care recommendations, one after the other. So strategy three is to align decision-making among the different clinicians who are part of the team with the priorities, so that we can, even though we have different perspectives or recommendations, we can try to align those recommendations among ourselves as a team by focusing on whether or not we're achieving the priorities that matter most to the patient. These strategies are probably obvious to you, and you've probably done some of them on your own and just didn't really think about it as a formal strategy. But we think that this is the way to sort of do it more explicitly now in a more structured manner than you've probably done before. So sometimes we need help with communication and decision making, and that's going to help us in this process where we're transforming from a statement like, you need to take this diuretic so that you can stay out of the hospital or keep your heart failure under control, to a statement that says something more like, I really do think that this diuretic might be helpful to you, even though it's causing some problems in urinating more often, because it's going to help you to do the thing that matters most to you, which is to be able to spend more time with your grandkids without getting fatigued. So we focus on decision-making and conversations on priorities and not just diseases. So this process might take several trials till we get to a place where you feel comfortable doing it and you got it down so that it actually works best for the patient. So we take what is the negative aspect of care, things that we're uncertain about over a particular therapy, and we turn it around to a positive because we're going to try different trials and figure out what works best. And we're going to do this systematically using serial trials until we get to the optimal mix of care so that we're actually achieving the patient's priorities. Now, there's always the inevitable kind of different perspectives that might happen from the different providers as we're thinking about our decisions. You'll be able to learn from those differences from each other's perspectives so that you're all sort of able to get on the same page and then use the priorities to help us get on the same page. Okay, so you've jumped to the next slide here. So before you describe the rationale to use the three strategies, it's helpful to note that they're not meant to be done sequentially. It's not that you have to do step one and then step two and then step three. They're not mutually exclusive. Sometimes you can actually use more than one strategy at the same time, and you're going to be using those at sort of different combinations to kind of help you get to that optimal decision-making process. If we're only able to briefly introduce the strategies here, we're not going to get to a point where you're mastering them. There's an online decisional guidance tool, and we'll reference this at the end, that you can go to kind of look at the strategies and review them more yourselves if you're interested in doing that. Can you click next? Okay. All right. So in terms of the 3 strategies, you know, a possible structure could be, you know, introduce a strategy and the rationale, give an overview of the various scripts. So I think, you know, as we go through this, these are the different rationales that we use for using the different strategies. So here's the first strategy, and we have a few rationales here. The first one is patients feel listened to and motivated, and they're more likely to adhere to these recommendations, right? Secondly, it gives clinicians and patients an anchor for decisions in the face of uncertainty, complexity, and trade-offs. And lastly, their sort of treatment effectiveness is measured by whether or not the goals are attained. So these are all sort of the rationales for why you want to use patient priorities as the basis for your decision-making rather than diseases. So some people might say, well, hey, diseases are what evidence is based on. I think the rationale here is, yes, that's true when it's only one condition, but now we've got multiple conditions. The evidence around these guidelines really does not apply as well. And so we're really using these different priorities as the best anchor to guide our decisions, as a way to motivate our patients. So it's something they're going to be willing to do, and for measuring whether or not something is effective or not, because we're actually able to get to priorities. Let's go to the next slide. So when you think about Mrs. B, there's many places to start. You now know that she's willing and able, now you know what she's willing and able to do and what she finds burdensome. So sometimes that's a good place to start. So for example, let's start with her diuretic. So go ahead and click next. So you might say to her, I know that the torsemide is difficult for you to use because it's making you go to the bathroom a lot more frequently than you want to. But if you'd be willing to cut back on some salt, then we might be able to decrease the dose of the diuretic, and you wouldn't have to use it so much, and you wouldn't be going to the bathroom so often. It's important to keep the fluid off of your body. That's the reason why we're taking it in the first place, so that you'll be less short of breath, and that way you'll be able to play with your grandkids more. So you sort of present the trade-off of, you know, you've got this medicine that you don't really like taking, and maybe you're not taking as much as you should, but you have a couple of options. You can take it a little more, and then you might have to go to the bathroom a little more, but it's going to let you play with your grandkids, which is what you told me is the most important thing to you. Or maybe there's a strategy here where you don't need quite as much medication, but then you're going to have to really be careful about the salts you take, and that's the way to get your fluid down instead. So you sort of talk about these trade-offs, and you're probably having these conversations already, but you really anchor them and focus them on the things that matter most to her, which is number one, the preference of avoiding having to go to the bathroom a lot, and then B, which is her outcome goal, which is having enough endurance to play with her grandkids for longer. So let's say, imagine it's your turn now. Think about her priorities. What are some of the other ways that you might think about communicating this decision-making process to her? So let's pause for a second. And I don't know, remember one thing that she said about her CPAP, and that she didn't really want to do her CPAP. So could you guys think about maybe how you can engage her with her CPAP? Does someone want to try to tackle that?
So it's Claire. I don't mean to hog the floor either, so if somebody else can jump in, feel free to. But if she's feeling tired, or like if fatigue is something that's getting in the way, to try to say, just like you said, keeping fluid off your body will make you less short of breath, that using the CPAP on a daily basis may help you be more awake throughout the day and be able to have you help do things with your grandchildren as well.
Absolutely, that's perfect. So, it's first acknowledge that she said CPAP is really something she finds burdensome and she doesn't want to take it anymore. And so that is an option, but then you can say to her, exactly what you said, there's a reason to use it, and maybe it might help you to actually have more energy the next day. And we can judge whether or not it's worth doing. Like, let's try it for a week or 2 weeks, or however, depends on the therapy, right? However long it takes to really measure if it's going to have some success. And then measure its success. Not, don't take that CPAP because Dr. Campbell tells you to take it. Take the CPAP because you're actually able to spend more time the next morning without getting tired, right? You said that well. Let's go to the next slide. So there's
such a great, yeah, that was such a great lead in to strategy too. Thank you, Anand.
Yep.
We were going to talk next about our second strategy, which is to use serial trials. And so we just identified 2 key approaches to her care. And, there's so much going on when there's multiple diseases, along with the potential interventions and treatments that we could give for each individual disease. It can seem overwhelming for the patient and for you. It also opens up, though, to the fact, and Anand, he talked about this, that when there's so many different things we can try, we've just created, an opportunity to look at that in a positive way, flip it, and say, there are a lot of things we could do. And that's actually kind of a nice thing, that we can take this one little step at a time. So exploring different interventions is a way to address the fact that there is no one right answer here. And if one thing doesn't work, there's always something else we can try. So we're not being unfocused or random in our approach. We're actually using serial trials that are guided by this patient's priorities. So we found it helpful to acknowledge this from the beginning. We're not sure what's going to work best for you. So one of our scripts can be knowing what matters most to you and what healthcare tasks you're willing and able to do. There are things I suggest we could try, but there are other things that we can also try next. So we're turning that uncertainty and no right answer into a positive, and we're offering patients hope, a sense of direction, and we're empowering them in their care. I think that those are 3 things that we all hope to do in every one of our clinical encounters. And by using this method, we're able to really arrive there with our patients. Next slide, please. So combining the first 2 strategies, we use patient priorities as a guide to starting, stopping, and continuing our interventions. In Mrs. B's case, she wants to volunteer. Maybe we could be talking about her, reading stories to her kids in the home, the grandkids who are visiting, to take care of her grandchildren. So we also know that the care that she's willing and able to do, or knowing how she feels about different care, helps us to narrow in on the things that we can try and offer possibilities that are actually consistent and honor what she is willing and able to do. So her fatigue was the thing that mattered the most to her. And because it was keeping her from being with her grandkids, we know also that she was willing to do exercises, physical therapy. She doesn't even mind getting blood work or getting some testing done. So on the other hand, she was clear that some of the medications and healthcare tasks are more tolerable than others. So it doesn't mean you don't talk about care that's burdensome, only that you can sort of put that in one of your second trials, or you could say, well, we'll approach that a little later. We can revisit CPAP if we need to. You can click again. So the one thing she wanted us to focus on, and what we can really drill down on during these initial encounters together for right now, she wants to focus on is being less tired so she can watch her grandkids. Next slide, please. So this is one of the ways that we can get started with this is by really focusing on the one thing. And this really kind of came out of this aha moment that happened during the development of patient priorities care. That even with that template, with 2 or 3 different health outcome goals, 3 or different healthcare tasks they don't mind doing, 3 or 4 that they didn't like, some medications they did like, there was still too much going on that led us to focus on identifying what the patient felt like was the most bothersome symptom or healthcare problem they felt was keeping them from their most desired health goal or activity. So this is why we start with the one thing so that our clinicians can really zero in on the language and decision making. So for Mrs. B, we know that we want to focus on helping her to be less tired, and so she can watch her grandkids. And one of the serial trials that we suggest here is retrying something that she felt burdensome, that CPAP machine. And I think Dr. Campbell had some really great ideas, and I'll just offer another script so you can click again. You might say to her, you know, I know that you don't like the CPAP, but I really think it's going to help you. Are you willing to try it again to see if it helps you reach your goal? We will judge how well the CPAP is working by your ability to play with your grandchildren, or, you know, in her case, to volunteer. We can then decide if any increased benefit is worth the burden. What do you think about that? There are several other options we could start with. If you think about what mattered most to her was to be less tired so she could walk with her grandkids, where would you start in terms of her disease or treatments? What do you all think in terms of serial trials for her? I think we've already hit a couple, but the idea here is that because of the multiple chronic illnesses, there are many things we could do. Does anybody else have any ideas? Well, one thing she was willing to do were exercises or physical therapy. Is there something along that line that you might be able to present to her in a way that honors her goals?
Hi, it's Claire again. I do think that, you know, if it's an energy issue that may, that, you know, we really think the physical therapy would help you. I know you've been through this before, but maybe giving it one more trial. And if it doesn't help, we can, you know, after a few weeks, readdress as well and see how you're doing with the therapy in terms of your energy level.
Yeah, exactly. And linking that energy level to the direct outcome of being with her grandkids a bit more. And what I find so interesting about patient priorities care is it's not actually about getting to the place where you can click off that you are, you know, with your grandkids 45 minutes a day, 5 days a week. It's a matter of just using that as this conversational, this place where you just join and connect with your patient at a place that you're really able to come up with decisions that align with who they are as individuals. So you can go to the next slide, please. So just this sort of linking you back into the CPAP as a troubleshooting point. And earlier also, there was the concern about sort of the competing factors of, you know, would aligning her care result in a fall, you know, or, you know, sort of having some dissonance in how a patient's goals are developed, and then linking that back to an actual clinical decision. First, we have to really zero in on something that is achievable and safe. So in this case, you know, if we think that the only way to getting her the energy, you know, to the place where she has the energy to be with her grandchildren is to work with a CPAP, we should check for understanding. So this would fall under troubleshooting rather than strategies, because we're still kind of trying to work to make sure that their goals are achievable. So here are some of the approaches to conversation when their goals are not likely achievable. And you can imagine having this sort of conversation with Mrs. B regarding her use of the CPAP. You told me, you know, you can't help with your grandchildren because you're tired. I know you don't want to use your CPAP, but I'm concerned that the sleep apnea is the reason why you're tired. Would you be willing to try a new CPAP mask for 1 week to see if it would help with your fatigue and allow you to spend more time with your grandchildren? And if there's resistance or hesitancy, you might explore further why the patient finds this treatment burdensome. Can you tell me what you find difficult or bothersome about the CPAP? It's also important to acknowledge the burden. Sometimes getting the emotions addressed can really make a big difference for people to access their higher thinking. You know, I know that the CPAP can be uncomfortable or difficult to wear each night. Just aligning with them and realizing and acknowledging that. And if ultimately your patient remains unwilling, acknowledge that and continue to work with the issue. You can reintroduce it later. I worry that we may not be able to achieve your goal. I wonder if there are other ways to fulfill your value of spending time with your grandchildren that could be more achievable. So maybe it's not being a reliable caregiver, but rather it's being together with, you know, the whole family and having the grandkids there, but having the support of others. So it really does take that extra layer of questions when goals are not likely achievable. So I thought that was a very helpful, you know, concern that your group already expressed, and it's something that we do bump up against, but it only offers us a chance to dive even deeper into that person's understanding of their illnesses. Next slide, please. So here are some additional strategies you might have thought of. You know, a trial of antidepressant, progressive exercise program, or even a referral to cardiac resynchronization therapy pacemaker if her ejection fraction qualified her for that. So these are, you know, sort of where you might go mentally when you're thinking about your patient's case and aligning her decisions. So that leads me into the next slide, strategy 3. You may recall that was aligning decision-making among clinicians with the priorities. So this is when there's conflicting recommendations, but you can also act as an advocate, knowing what matters most to your patient, reaching out. And this is something I do almost every time I have an encounter that's patient priorities delivered. I'm constantly reaching out to the specialists with the language of, here's what matters most. Here's what this one thing is. Do you think it might be helpful if so-and-so goes through a stress test? Or would you consider liberalizing their diet in the case of diabetes? So this alignment is a major part of our role in primary care. We talked earlier about conflicting recommendations, often resulting from clinicians considering different information, different diseases, or different outcomes in their decision-making. Some clinicians feel particular guideline apply, some don't. Guidelines for one condition could conflict with another. One clinician might feel the patient's preference overrides guidelines. With all these possibilities, it's no wonder that patients get conflicting messages from various clinicians in their primary and specialty care. Next slide, please. So how can we align decision-making when clinicians don't always agree? When clinicians don't agree, it's most often because one feels it's important to follow a particular guideline, and the other clinician may not feel that the guideline applies to this patient, or that the likelihood of benefit does not outweigh the likelihood of harm or burden. And one good example about that could be cardiac medications and trying to decrease falls in patients at home. So the clinician might be concerned that we're asking a patient to do something that they either don't want to do or unable to do. So you have multiple players here. But here are the steps that we found in our work with primary care clinicians and cardiologists. It's based on a collaborative negotiation. So this is often used in business when maintaining a relationship is important, but colleagues disagree on a specific plan. So the first step here would be to acknowledge the uncertainty and that there is no one best answer. Next bullet, please. We can identify and reconcile the sources of differing recommendations and decide based on the patient's priorities, not just the disease-based trade-offs. So we can brainstorm alternatives until you arrive at a compromise or a solution. Okay, next slide. So let's say that you can click again. The cardiologist felt strongly that beta blockers were a guideline recommended and one of the most effective treatments, potentially for survival, but also to try to prevent the progression of her heart disease. And the primary care provider really felt that the metoprolol was one of the things that was causing this fatigue and preventing her from enjoying her time with the grandkids. So they came up with these opposite suggestions to Mrs. B. And the conversation is really around agreeing on information that should inform the decision for the patient. And in Mrs. B's case, it's about the likely benefit and trade-offs in her own priorities. In terms of a likely benefit, for example, so you can click again. We often don't know about the absolute benefit, even where there's strong evidence. The evidence was not often evaluated on patients with 10 different conditions. And these other conditions affect health, function, longevity, and response to each treatment. So at the very best, there may be modest benefits for adults with multiple chronic conditions, despite the available evidence from single disease guidelines. Acknowledging this uncertainty supports the need for greater emphasis on our patients' priorities. Next slide, please. So we first acknowledge that uncertainty may arise from the different perspectives and sources of information that clinicians may have. In Mrs. B's case, her PCP thinks that the fatigue is likely from her metoprolol and wants to stop it. Her cardiologist feels that the metoprolol is important to her long-term survival, and so a good place to start is a dialogue. And that can be written. I do chart messaging. CPRS has its own functions that I'm not aware of. But I'm sure you can imagine reaching out to your local cardiologist. And this can be written or spoken by phone or whatnot between the clinicians. Mrs. B, one of our shared patients' main concern is her fatigue, which is keeping her from doing the activities that matter to her. While there are several possible explanations, as a first step, I think we should stop her metoprolol. Its main benefit is survival, which is not her main priority. What are your thoughts? Next slide, please. So, you can click through all. That's helpful, thank you. So the cardiologist is saying, I'm concerned about stopping the metoprolol. It took me several months to get her to this dose, and her heart failure is severe. The PCP could say, well, but she felt better without this medicine. The cardiologist could say, did you explain that her decision could shorten her life? And PCP did. I did. I said, but she said she'd rather just feel better today so she could be with her grandkids. The cardiologist said, well, I wonder if she'd agree to restart a lower dose. If she notices the fatigue worsen again, then we could stop it altogether. And the PCP agrees with this. That sounds like a good compromise. So you can imagine how a conversation like that might occur between you and a specialist. Next slide, please. So what are some other possible conflicts that you think you could come up with for a patient like Mrs. B? If you would like, anybody have any thoughts on this or?
Hi, it's Claire again. Sorry to keep coming in here, but I think, even I said at the beginning, one of the conflicts, even not necessarily between the PCP and the specialist, but like the PCP and home-based primary care priorities with like us trying to decrease fall risk, but we're having her do maybe more physical therapy, that there are sometimes competing priorities even within the group itself, outside of the specialist even.
Yeah, so that's part of the non-mutually exclusive concept in patient priorities care. So reducing fall risks is one of your quality metrics. You know that there are multiple ways at reducing fall risk that don't involve keeping somebody from moving. We know that keeping people on bed rest is not good for their overall health and function, but rather there are these multitude of different approaches that are required in order to really decrease the risk of falls in each individual patient. And to motivate patients towards some of those healthcare activities, using their patient priorities goal is actually quite helpful. So rather than framing it that, I want to keep you from falling so you don't break your hip, we can say, I know that a hip fracture would, really, really decrease your ability to be with your grandkids. And I think it's one of the one thing that if we address that aspect of your care in an informed way, that's informed by what you're willing and able to do, we're really going to keep you watching your grandkids after school. I think that sort of takes and offers back the empowerment to that individual, saying, I acknowledge to you that you're not waking up every day necessarily, maybe you are, afraid of falling, but that wasn't the one thing that you noticed and wanted to bring up today in this visit. You talked about fatigue. Well, if I can get you stronger, I know that's going to reduce falls. That's important to me. And I can frame it around what's important to you, which is to be with your grandkids. Does that help a bit without getting into specific decisions?
Yes, thanks.
Yeah, so they're not mutually, your quality metrics build nicely with patient priorities care. Are there any other comments or ideas on what challenges you might be facing with other, quality or any other conflicts that you think might arise? Okay, so we can go to the next slide. I hand it back to Anand. Thank you.
Thank you, Claire. So thank you for your attention and interest today. And just to summarize, that we really introduced to you guys the strategies for aligning care decisions with patients' priorities, and then shared some tips and scripts for getting started on these strategies. We'll hope you'll be able to come up with some of your own ideas in terms of how to work these strategies, your own sets of tips and scripts that you might be able to incorporate as you move forward through this process. Today, we're really only able to do an introduction to these concepts, and we hope that you'll participate with us as you get more skilled at patient priorities decision making. And then there are some more tips and scripts on our website, and the link to the decision guide troubleshooting. I think Dr. Campbell has sent those to you already, and we can do that again after this session. But there's again a website that we have that walks through a number of these things and links. And Dr. Davenport was actually heavily involved in the development of that website. We've also given a quick example, for example, of Mrs. B's reluctance to use the CPAP, or when health outcome goals are unrealistic given the patient's health status and trajectory. We also suggest ways to handle the inevitable situation which you have to accept a patient's decision that you might not agree with them, or when there's some conflict between two different members of the clinical team in terms of their perspective about what's best for the patient. And in each of these scenarios, using the priorities as a strategy and a medium for conversation and for deciding what is an appropriate outcome and how to do serial trials of different care options to help you to get to those priorities. Getting comfortable aligning your decisions with patient priorities will take some time and practice. What you try to do it one patient at a time, and then review the additional guidance. And over time, this becomes natural, and you're able to sort of do this without having to go back and forth between the guidance and other scripts and things like that. Next slide. Okay, this is our last slide, and we're sort of just summarizing with a lot of information on this page. You can just click through till it all appears. So thank you again for your interest in patient priorities care. This training is just the beginning of your journey as you approach decision-making for older adults to align their care with the priorities of your patients. We've developed a wide range set of tools to assist you in this journey. These tools are also found on the website, patientprioritiescare.org. In particular, we've developed a set of troubleshooting tips and tools for clinicians in the process of aligning healthcare decisions with your patient's priorities. We've included a link to this decisional guidance page here. That's might be a little hard to see here in the purple text. And it's a link to there. And there's some additional tools on the website for patients, for caregivers, and for clinicians. We're also launching a web page on the site that includes a self-directed guide for patients and caregivers to assist in the process of identifying patient priorities. So that's all we have formally for today. We can pause now to answer any questions or address any issues that you may have.
Dr. Nayak, thank you for the presentation. It's definitely really interesting, and I think it will help us as we go on and start to adapt patient priorities care in home-based primary care. A lot of what you said was kind of, on medications and seemed to be very PCP guided, but I feel like this can be used across all disciplines, whether or not it's getting them to help align what matters most with being compliant with their diet, or getting them to work with physical therapy and getting home health physical therapy in there. So I just wanted to make that point that it's not just the PCPs who are going to be doing this aligning, but that we're going to be talking about it at IDT and trying to get everybody on the same page with what matters most, and trying to get from each discipline how we can get them achieving their goals.
I think that's a key point, and one reason why I'm excited for a team like home-based primary care to do this, because it really allows, the full array of healthcare professionals to be involved, and you all have your own set of care options that you're sort of in charge of, or you have the most access to. And I think it'd be great to have conversations like we described in these strategies about comparing different perspectives of the different members of the team and how well that those different care options are actually helping to get to the outcome goal.
Dr. Nayak, excellent presentation. Dr. Nayak, I wanted to ask you a question regarding that template which you mentioned. Where is it embedded? Is it under extended care line, or is it, or should we go through CAGs and have it?
So we haven't done it that way because I think sometimes that's a barrier to actually getting it implemented. Mm-hmm. So it's something that we've done more in terms of, like, we can cut and paste it into Word and then put it into the My Templates portion of your note, so each person who's working on it can make it part of their template.
Dr. Jacob, that's something that I have sent out before too, that I can resend. It's basically the Word template that you can put into My Templates, as Dr. Nayak had stated.
Yeah, and the VA is okay with it.
Yeah.
Dr. Nayak, thank you very much for the presentation. I have a question. When I've been trying to could you please close your, I'm sorry, just mute yourself a little. I've been trying to implement some of the questions into my visits, just to start getting like a glimpse of how it feels. But for example, how do you start addressing this PPC? Because, for example, like when I start trying to ask about connecting, enjoying life, functioning, there are like 3 or 4 different questions. So how do you prepare yourself before you go in and see the patient and see what am I going to ask based on what I know about this patient, or you just go along with what the patient says? Like for example, I have, just to be a little bit more clear, I have this 71-year-old, very severe COPD in the process of transitioning to hospice. And when I started doing these PPC questions, one of the first things he told me, like when I asked him about his goals of care, he told me, like, all I want to do is breathe comfortably, die comfortably, and see my grandchildren more often. That was all he cared about. And, a transition to hospice will take care of the first 2. But seeing the grandchildren more often, the caregiver was against having their own children at home because of COVID. So how would you have addressed that? Like, just like a little bit of help here, because I was stuck there.
Sure. So Dr. Davenport, jump in as well. You know, I think, let's back up a little bit. So I think what you're describing here is the step before. Today, what we talked about was care alignment, you know, aligning care with the identified priorities. I think a lot of what you're describing is the step before, which is identifying your patient's priorities. And so that's that first set of, that first training that we did. And so in that case, you know, I do recommend using kind of a fixed script that we have that helps explore all the different values domains. And you seem to have identified a few of them in this example, which is, you know, spending time with the grandkids, you know, that's sort of the social connection value. You know, the managing health value is really minimizing symptoms, feeling less fatigued. Maybe you might also identify an important, a meaningful activity that person likes to do, some sort of enjoyment or activity they like to do. And then maybe something around independence, a functional activity that's important to them that they want to be able to do more of. So I think that those are things that you'd identify as different values. And then the values then are transformed into specific realistic goals, you know. So that might be, you know, I want to be able to walk from the kitchen to the bathroom without getting short of breath, you know, several times a day. That's a specific outcome goal. Or I want to be able to spend 30 minutes playing with the grandkids, you know, a couple times a week. You know, that's a specific outcome goal. But then you raise an issue, and that gets more into what we talked about today, which is actually sometimes conflicts between trade-offs, right, between different goals or different priorities. So even though he or she, sorry, wants to, wants